I'm presenting two siblings, a brother and his sister. They both have the same phenotype. I'm going to start presenting with the elder boy. He's a 20 years old male, medically free, no special habits of medical importance. First out of two affected siblings, student, right-handed, born and lives in Menofia. He has a personal history of meningitis at 1 year of age, and he spent 15 days at Fever Hospital. Normal developmental milestones until the age of 2. Family history: consanguineous parents, first degree cousins, similar condition only in his younger sister, no other similar conditions in the family, and no family history of neuromuscular diseases, autoimmune, or other hereditary conditions. The complaint of the patient: gradual onset, progressive course of bilateral upper and lower limb weakness of 18 years duration. The condition started since the age of 2, preceded by normal developmental milestones when the patient started to develop multiple falls due to distal muscle weakness of both feet, associated with decreased tone around the ankle joint, foot drop, and foot deformity in the form of inversion and hammer toes. He underwent corrective surgery for both feet at the age of 5. Moreover, he started to develop insidious onset of bilateral upper limb weakness, distal more than proximal, associated with decreased tone around the wrists, with drop hands and clawing deformities of fingers, leading to loss of the fine movements of the fingers. In addition, he started to develop bilateral lower limb proximal weakness, manifesting in difficulty going up the stairs, and to less extent proximal muscle weakness in both upper limbs, leading to difficulty lifting his arms in activities such as combing his hair. Moreover, he started to become unable to close both eyes fully during sleep, and started to have limited facial expressions noticed along the years, not corrected by emotions. All through the history, there were no other cranial nerves affection, no sphincteric affections, no diurnal variation, no sensory affections, no fits at any point of the present illness. General examination of the patient. There was scoliosis of the back evident by palpation, clawing of both fingers, hammer toes, bilateral wrists and foot drop. There was atrophy of the whole muscle bulk, no skin lesions. Neurological examination: he had bilateral lower motor facial, nasal intonation of speech, tongue fasciculations were present. Regarding a motor examination, there was bilateral decreased tone around the ankles and knees, ankles and wrists, atrophy in both upper and lower limbs, stiffness of the thigh muscles, no tenderness, bilateral lower limb weakness and upper limb weakness, distribution lower limbs more than upper limbs, right more than left, distal more than proximal, with truncal weakness noted. Reflexes were lost all over, coordination, superficial sensation intact, but the patient had positive Romberg sign and sphincters intact. Gait: there was wide based stamping gait with a bit of lordosis. Regarding his investigations, CPK was within range since the age of 2. Serum lactate was high. Muscle biopsy done 2008 showed myopathic atrophy, and Shurer nerve biopsy showed marked axonal degeneration with chronic demyelination and remyelination. The whole MRI body muscle. These were the results. Marked thigh and below knee fatty atrophy. This was a recent one. And mild back and pelvic girdle fatty changes, mild below knee interstitial edema, bilateral minimal ankle and knee effusion, right moderate dilatation of pelvic calyceal system. The impression was described as chronic myopathy associated with edema in the calf muscles, suggesting acute insult on top of chronic. With right marked hydronephrosis and thin renal parenchyma. The same findings were found in his younger sister. She's a 15 years old female with irrelevant personal history, no history of meningitis like her brother, and similar family history, of course, to her brother. Also, the complaint is bilateral upper and lower limb weakness, same distribution, same symptoms, but to more aggressive degree, in the form of an feet deformity are still evident. She didn't have any corrective surgery. The facial nerves are more involved, with more gaps between eyelids. Upon attempting to close her eyes, she showed more weakness, but had similar distribution to her brother. The serum pyruvate is normal. Serum lactate was 63 with an upper limit of 19.8. CPK normal along the disease. This is nerve conduction of the girl. It's done recently, 2 days ago, showing spontaneous activity, positive sharp waves, and fibrillations. No motor unit action potential. EMG showed also sharp waves and fibrillations. The conclusion is complete axonal neuropathy affecting motor fibers of both upper and lower limb with signs of degeneration at EMG.
what's your opinion؟ طبعا احنا خلينا عشان الوقت ان هي تقول الهيستوري الاكزامينيشن انفستيجيشنز، بس اكيد انتوا يعني عاملين انفستيجيشنز كتيره، وصلتوا لايه؟ what is your diagnosis؟
هو ال provisional diagnosis of the patients إنه it's something congenital, probably distal myopathy. لأنه all other investigations were not يعني were not confining ل any other symptoms. يعني what was against the neuropathy إن there was no sensory affection خالص.
what about the nerve conduction and EMG؟
ما هو that was the second differential diagnosis إن هي congenital
لا
neuropathy.
يعني احنا دلوقتي عندنا two a brother and a sister consanguineous parents, so it is autosomal recessive, and they came with distal weakness and deformity, motor but not sensory.
Yes.
And you did the CK was normal,
Yes.
but you did the serum lactate, it was very high, and this must be in a good laboratory to be sure. And you did nerve conduction and EMG. It was not myopathic, but it was axonal neuropathic, and there is denervation potential. So we'll put neuropathy first before. But what is found in the MRI, there was fatty infiltration. There was atrophy of muscles associated with fatty infiltration.
Yes.